Okay, so now we're going to move on to anti-infective agents, and this will include antibacterial and antiviral agents. I'll also emphasize a few key points that you will see on exams, and they always keep coming up, both in lab and lecture, not only pharmacology. So we'll go ahead and get into this here. So anti-infective agents, just some terminology that we want to make sure everybody's clear on. And this term actually causes a lot of issues here, the term chemotherapy, because we often think that chemotherapy is specific to cancer patients. But chemotherapy is just the application of a chemical agent that has specific toxic effects on a certain disease process. So when we give somebody an antibiotic, for example, for a bacterial infection, we are giving them chemotherapy, but we're giving them chemotherapy for an infection. When we give somebody an anti-cancer drug or a certain medication that modifies the way cells divide, that treats cancer, that's chemotherapy for cancer. So chemotherapy doesn't always mean cancer. It just means that I'm giving a chemical agent that has specific effects on specific disease processes. An antibiotic, however, is a chemotherapeutic agent derived from a living organism that kills other microorganisms. So here's a question. Do antibiotics work on viruses? No, right? Viruses, how do viruses work? Are they like bacteria? No. They do things a little differently, don't they? Bacteria are actually true cells in the conventional sense, that they have a cell wall, they have nuclear material, they have organelles inside of them, and they produce, they make their own genetic material. Some bacteria have RNA, a lot of them have DNA. They have some of the same processes that we have in our body, like transcription, where they can copy their DNA and then transcribe that DNA by ribosomes. So microorganisms, bacteria, are true cells in the conventional sense. Viruses, however, are viruses self-replicating?
No.
No. How do they replicate? How do they divide?
They use a host cell?
Yeah, they use a host cell, and they generally will inject their genetic material into the host cell. It can be RNA, it can be DNA, and then that host cell will, in essence, become a virus factory, make viruses, eventually die and release viruses. Very, very different ways of working. Antibiotics work primarily on bacteria and the processes that go on in bacteria. Antivirals affect some of the processes of viruses and how viruses replicate. Okay, so antibiotics treat bacterial infections. A broader term may be used to treat, an agent used to treat infectious microorganisms. Okay, well, yeah, I'm not, no, that's just more, I think that's more confusing. We know what an antibiotic is, and we know what an antiviral is. Do we know what antifungal agents are? Okay, they treat fungal, sometimes protozoal infections. Is there a difference between a bacteria and a protozoal or fungal agent? Yes. What are some of the big differences?
Spores?
Bacteria can do spores too, right? Certain bacteria can do that. Bacteria are what type of cells? They're what we call prokaryotic cells, right? And they have very distinct differences in that their nucleus. Is their nucleus bound by a membrane? No. The bacterial genetic material is just kind of spilled out in the middle of a bacteria, kind of floating around. In eukaryotic cells, like protozoa, yeast, plant and animal cells, the nucleus has a membrane, right? Its nuclear material, DNA, is bound by a membrane. That's one major difference between bacteria and protozoal fungal cells. The other major difference comes into how they make proteins. How do we manufacture proteins? Okay, so we transcribe, DNA into messenger RNA. That leaves a nucleus. It hops a little ride on the sarcoplasmic reticulum, and then it goes to a ribosome, right? And the ribosome reads it and translates it in those base pairs into proteins, or amino acids and proteins, right? Bacteria have a very similar process, but the ribosomes of bacteria are very different from the ribosomes of protozoa, yeast, plant, and animal cells. And as you will see here in a little bit, we make antibiotics that can target those different, what we call subunits of the ribosomes. Okay, so empiric therapy, what does empiric mean? What does empiric mean? Okay, most likely.
Give a therapy based on your best guess.
Okay, empiric knowledge, and that is to say, okay, I've seen this 100 times before, 1,000 times before, the same thing, and if I give this, it'll work. That's what empiric therapy is. And often we will treat patients empirically, and that is to say, somebody comes in and they have signs and symptoms of a certain type of pneumonia. Even though we don't exactly know what the pneumonia is, we don't exactly know what antibiotic will work against a specific pneumonia, we know as a general rule of thumb that if I give a certain antibiotic, it will generally work. Because how long does it take to get a good culture and sensitivity? We do let's say we do a sputum culture and we find out what the bacteria is and what it's sensitive against. How long does that take? You guys did it in microbiology, right? Yeah, 24, 48, even 72 hours in some cases. Are we going to withhold antibiotics for 1 to 3 days? No. So what we're going to have to do is, while we're waiting for that culture and sensitivity, we have to make a choice, you know, and it'll be an empiric choice. What antibiotic is most likely to work? Okie dokie. So we have different kinds of infections. This is a table right out of your book here. You talk about pharyngitis, group A strep. Streptococcus, we know, is a major cause of pharyngitis or strep throat. Can that be a big issue? Yeah, it can cause all kinds of problems. It can cause scarlet fever, rheumatic heart disease. I can have antigen-antibody reactions that result in things like renal failure. Bronchitis, Haemophilus influenzae. Bronchitis is often viral, too. Bronchitis is often viral. And unfortunately, we often treat viral bronchitis with antibiotics. Physicians do that quite a bit. I come into the office, I'm hacking and coughing a little bit, I'm a little uncomfortable, and I say, Doc, do something for me. And he can either say, oh, I'm going to give you an antibiotic, I'll put you on some Zithromax, I'll put you on a Z-Pack, and you'll get better in 5 days. But would you get better in 5 days normally? Yeah. Most cases, a lot of patients don't need antibiotics for bronchitis, but there is a lot of over-treating that occurs. And it kind of is what it is, but it has led us to some interesting problems. Sinusitis, Streptococcus pneumoniae. Chronic sinusitis can be generally anaerobic, can penetrate anaerobic tissues like Staph aureus. Different types of pneumonia, I can have what are called community-acquired and hospital-acquired pneumonias. These, again, Streptococcus pneumoniae and Haemophilus influenzae are bacteria that just continue to show up time and time again. Otitis media, what is otitis media? Yeah, middle ear infection. Streptococcus pneumoniae, and believe it or not, many cases of ear infections, otitis media, are viral. Believe it or not, it's interesting. I've worked with a group of physicians that they call themselves purists when it came to things like this, and if somebody came in complaining of an ear infection, they actually did not treat it initially. Like, no, let's give it a few days. I know it's uncomfortable. We'll give you some pain medicine, and we'll see if it just spontaneously resolves, because a lot of them are viruses. Most cases, if your ear hurts and you go to the doctor, what are they going to do, though? They'll put you on an antibiotic, aren't they? But that's not working like it used to, and there are lots of problems that we're running into. Epiglottitis, what is that? What's that? Of the epiglottis, right? Is this a life-threatening issue? Yeah, this is a life-threatening problem. Haemophilus influenzae. Croup Streptococcus aureus. Interesting. I want you to just put a line through that there. Because what is the most common cause of croup? Is it viral or bacterial? Bless you. Croup is most often viral. It's a viral infection. Epiglottitis, definitely bacterial, Haemophilus influenzae. Croup, however, is often a viral infection. Okay, normal flora. Do we have bacteria that normally inhabit the skin, the gastrointestinal tract, the nares, turbinates, all that? What do you guys think? Yes. Can that bacteria be helpful? Yes, especially gut bacteria, right? Gut bacteria help us absorb a lot of things that we wouldn't normally be able to absorb. Do we have Staphylococcus aureus all over us? We do. Is it normally a problem? No. Can it cause infections, however? Sure it can, absolutely. Normal overgrowth, though, of flora can be a problem. Do we normally have fungus and yeast on us? We do, but it's generally in such small quantities that doesn't cause a problem. But let's say I get immunocompromised, maybe I'm receiving chemotherapy or I have something like HIV, then this fungus can overgrow and I can get things like thrush and even systemic fungal infections. Okay, common normal flora in sputum sample. So if I do a sample of sputum, I would not be surprised to find all these bacteria. Are all of these disease-causing or pathogenic? Sure they are. It's just when they become, when they start to overgrow and they start to create a proper infection, we run into issues. Alpha hemolytic streptococci. You guys are familiar with alpha beta hemolysis? In microbiology, did you do a CAMP test? Yeah, and you got to see that alpha and beta on blood agar, I believe is what they use. Yeah. Haemophilus, Neisseria, when we talk about some of your gram-negatives, and Staphylococcus epidermidis. Okay, so bacterial classification. And this isn't going to go into the detail that you went into in microbiology. This is going to be a bit more superficial. Broadest classification is based on bacteria that need oxygen versus bacteria that don't necessarily need it. And that's aerobic versus anaerobic. Mm-hmm.
You know, you talked about how the steroid can destroy the bacteria in the mouth, but what about all the antibiotics? Which bacteria?
Well, steroids don't destroy bacteria. Actually, they make us more prone to
And that's
infection.
what causes the thrush?
It can.
Okay, so the antibiotics, so what bacteria are they destroying? Are good bacteria?
I'm sorry?
If you take too many antibiotics, it destroys your...
They can destroy like gut bacteria.
Yeah.
Like normal bacteria in our gut
Right.
can kill that off, and then we can develop an infection because the normal bacteria in our bodies keeps other types of bacteria away, keeps them at bay, and if we kill that bacteria off, then we can get lots of issues.
So why don't they give probiotics when you get antibiotics?
They often recommend that, right? Have you ever had an antibiotic and they tell you, well, first thing they do is they ask you, are you on birth control? Are you on oral contraceptive? If yes, you may want to consider using a different method for a month. And then a lot of times they'll say, hey, go ahead and find yogurt that has acidophilus in it to supplement. They often will tell you that, probiotics. Do we see these kinds of infections, these opportunistic infections? Pseudomembranous colitis and things like that occurring in patients that receive chronic antimicrobial therapy? Yes, we do. We're not really going to talk about it in any detail here because that's something that we typically don't deal with in respiratory. It's out there. Now in nursing school, if you go to nursing school, they spend a little more time on antibiotics than we will. But we focus on some different things that they don't. But yeah, definitely things to consider. Okay, so anaerobic versus aerobic. And you guys all know what that is. We can look at their shape. This isn't as helpful, though, looking at the shape of bacteria, believe it or not. I can have rods, I can have spheres. I have them bunched together like staph, and that's what we call Staphylococcus aureus. It literally means grape-like clusters. We can have chains, and so on and so forth. A very helpful test we can do is the gram stain, and I know you have to do gram stains. You went ahead and you put some crystal violet on there, you decolorize it with alcohol, and then you add some Morden's iodine and then take a look at it under the microscope. Positive organisms will generally stain dark purple or blue. Negatives will stain kind of nice and pink. And we know that positives and negatives have different general characteristics. And there are different types of antibiotics that are more effective against, say, a positive versus a negative. Again, this is more empirical, though, right? But can we easily and quickly get a gram stain on let's say we do sputum culture of a patient? Is this something quick and easy to do? Absolutely. And you guys got to do it in micro, or most of you should. It literally takes minutes to do. It's really easy. And this is a part of that empirical therapy. That, okay, they've got a gram-negative rod. What kind of antibiotics do I need to choose? Okay. Gram-negative organisms, it says they're harder to treat than gram-positive. I want you to go ahead and just put an X through that. That's not the case. Certainly not the case anymore. Because we have some pretty nasty gram-positive, right? MRSA, methicillin-resistant Staph aureus, and DRE, vancomycin-resistant Enterococcus. Those are both gram-positive organisms. So just kind of forget about that. Again, I think this book was written in, 2006 and copyrighted in 2008. So it's a few years behind. Okay, so the bacterial cell wall. I don't really like this picture, actually, so just put an X through this picture. It's a little misleading. When we look at the gram-positive cell wall, the gram-positive cell wall has a very thick layer of peptidoglycan, right? It's very thick, it's very prevalent, and that allows gram-positive organisms to live outside of the body and do okay, right? Things like staph and even strep, because they have this really thick wall of peptidoglycan, they can protect themselves from the environment, right? So they can live on the surfaces of tables, for example, and beds and like that very easily. Gram-negative cells, however, and that's why I don't like this picture, it's very misleading, their peptidoglycan is in a very thick layer. No, they have a very thin layer of peptidoglycan because, one of the reasons is because water needs to get in and out of them a lot easier, because where do a lot of gram-negatives live? They live in aquatic environments like our intestines or stomach. They can create a capsule around themselves to help protect. Sometimes if they get outside of the body, they can create a capsule to protect themselves. But let's say something like E. coli gets out of the body. Is it going to last very long if it dries out? What do you guys think? No, it can't, because it can't really protect itself from fluid loss like the positive cells can. But gram-negatives can cause lots of issues when you talk about septic shock, for example. In patients that get septic, often the cause of septic shock is gram-negatives because they can release toxins from their cell membrane, right? We call endotoxins that cause vasodilation and cause our heart to fail and cause all kinds of different problems. Okay, so these are this is a good table here. These are common gram-negatives, gram-positives. Generally, if it has a cocci after it, it's going to be gram-positive. Strep and staph are both positives. Your gram-negatives have some interesting names: Pseudomonas, Haemophilus, Klebsiella, and if you guys could just throw in E. coli as well. E. coli, I don't know why they don't have that on this table. It is one of the most common, and it is one of the most well-studied and well-known of the gram-negative. We actually use E. coli, right? We'll often, and when we talk about recombinant DNA technology, we'll often inject DNA or RNA into E. coli, and those E. coli will make different drugs for us. So I would definitely throw that in there because it's such an important, well-known. And what flavor, what version of E. coli is of great concern to us infection-wise? It's E. coli OH157, right? Yeah, coli OH157, that's the one that causes lots of, we do have a few people die over the summer of that, of the E. coli, gastroenteritis. Okay, susceptibility. How are you guys on what we call the culture and sensitivity? Did you guys get to do that in microbiology? So what we did is we take a culture, right? And we take our media. It can be blood agar or something on the lines of that, something that the bacteria grow on. We culture it, and we have little discs of antibiotics on that culture, right? And we know that if bacteria grows really close to those discs, whatever that antibiotic is, it's probably not going to be very effective. But if there's a big zone around the disc where bacteria are not present, well, then we know, hey, that might be an antibiotic to choose. That's kind of an old school method called the disc diffusion. There is another method called the broth dilution, and you'll see that used as well. So here we have our little discs. You can see that the bacteria is grown around those guys. Probably don't want to use those antibiotics, but this might be a good antibiotic to choose here in the middle, where I have kind of a zone of no bacteria. Broth dilution. Broth dilution is nice because it's very quantitative. We can dilute the concentration of antibiotics down, and we know exactly what the concentration is. We place the organism in various test tubes. The test tube with the lowest concentration of antimicrobial agent that inhibits growth is called the MIC, or the minimal inhibitory concentration. MIC is at levels that cannot be safely achieved, then the organism's termed resistant, right? If we have to give such a massive dose of antibiotic to get rid of that it damages other body systems, well, probably don't want to choose that antibiotic, choose something else. And here's just a dilution, how we can dilute the concentration of drug. Here I have, say a concentration of 1, and then 1/2, 1/4, 1/8, 1/16, 1/32. So let's say that way down here in the 1/32 1/32 concentration, this antibiotic kills all the bacteria in there. Would this maybe be a good antibiotic to choose? Sure, but let's say that it's up here, that I have 1 and it kills all the bacteria. Well, that's a pretty big concentration. Maybe we want to look at a different. Okay, mechanisms of resistance. This should be nothing new, guys. Widespread resistance is that a big deal in healthcare right now? What do you guys think? It's a huge deal, right? It is a huge deal. When I was doing my prerequisites to get into nursing school back in the 90s, this wasn't particularly a big deal. And that wasn't too long ago. Well, I mean, for me at least, it wasn't too long ago. And I remember that I wrote an interesting paper in microbiology. It was a really good paper, I thought, a huge one. And it was on kind of this new concept, not new, but just not well known by a lot of healthcare providers. It was known as conjugation. And now everybody knows conjugation, right? Because that's one of the primary ways bacteria become resistant, is they acquire plasmids from other bacteria, and it's called bacterial conjugation, and that's how they can require genetic material for resistance. And I think that's a real telling concept about bacteria, and I don't know if you guys would agree with me or not, but basically the way of thinking about conjugation in human forms is, let's say that you guys are all to die suddenly, and you were to explode, and all your genetic material is floating around this room. And then I came in, and I started looking at all this DNA of all you guys floating around. I go, hey, I like that gene, I'm going to take that. I like that gene too, I'm going to take that. And I make myself into a superhuman by cherry picking, what DNA I like. That's a pretty, if that happened in a human, that'd be a pretty scary thing, wouldn't it? That's what conjugation is on a bacteria. That's what bacteria can do. They're very good at cherry picking DNA, and they're very good at mutating. And we see that, right? We see that a lot. How effective are a lot of our antibiotics now? They're not. What about our latest and greatest antibiotics? Our cutting edge frontline antibiotics? They're failing, right? They're failing. We now have diseases that have not been of any particular concern, like things like gonorrhea. Is gonorrhea a big deal? No, it's not a big deal, is it? Oh, you got gonorrhea. Don't worry, we've got antibiotics for that. You're going to be just fine. We now have forms of gonorrhea that are resistant to every known antibiotic. Every known. We have no way of treating it. None whatsoever. It's a scary thought that we now have disease. That we are now going back to the 1700s, early 1800s. Antibiotics really only came about right before World War II, right? And in less than 100 years, we have gone back You know, we're going back to the Renaissance as far as our ability to treat some of these infections. It's pretty scary stuff, actually. One misuse of antibacterial agents. This has been huge. Misusing this. Those of you guys that are, you know, I'm not sure how, if anyone is maybe pushing 50 here. Anyone right around 50? No? So my wife is going to be 50 here in a few months, and she remembers a time when you got antibiotics for everything. You know, you got sick, you got a sore throat, you weren't feeling well, you went to the doctor, and they gave you penicillin, right? And they would give that for everything. Everything that ails you. If you're depressed, we put you on some penicillin. It's literally that bad. That bad. Well, what happened? What happened? We're giving penicillin all the time, right? And we're killing all these bacteria, but are there just a few bacteria that are resistant to penicillin? Yeah. Well, what happened to those few bacteria? They had no competition, right? There was no natural selection going on. All those other bacteria are getting killed off time and time again, and these little resistant guys are like, hey, this is some good stuff. I'm going to live the good life. And they started living the good life. They started dividing, and they started becoming the most common bacteria. When penicillin first came about, 90% of all of the staph infections were sensitive to penicillin. Now, over 90% of all staph infections are resistant to penicillin. Okay, we managed to do that in less than 100 years. Good for us. Okay, another example, broad-spectrum antibiotics, what we call shotgunning. I use a real broad-spectrum antibiotic against an infection where I could have used a narrow-spectrum antibiotic. I want to be as specific as possible. We see a lot of that as well. Okay, resistance also develops when a patient does not finish the full course of therapy. And we see this a lot down here. We give somebody an antibiotic, they start taking it, 3-4 days later they feel better, and they quit taking their antibiotic. Well, that's nice. You didn't get rid of all those bacteria, so now I have bacteria that may have had a little bit of resistance to that antibiotic, and they ended up surviving, right, because we didn't kill them off. And the bacteria that are sensitive are now able to acquire DNA plasmids from these bacteria that are a little sensitive, and it gets worse from there. Destroys weaker pathogens, gives symptomatic relief, but the stronger strain is able to multiply and reach a level where the symptoms return. But now the antimicrobial agent may not be as effective. Okay, monitoring therapy. We can look for a clinical response, right? Our patient gets better. Their symptomology improves, the signs improve as well. The clinical response is good. We can also look at the white count. You guys covered labs yet, lab values? Yes. So a white blood count may not mean much to you guys right now, so, but it will here in a couple semesters. A microbiological response means that the organism is being eliminated. Some medications are really toxic. Antibiotics are very toxic, and we have to monitor blood levels. We get what we call peak and trough levels. Antibiotics like vancomycin, for example. People on vancomycin, we get peak and trough levels. We don't, as therapists, but that's something that the nurses have to worry about and the physicians have to worry about ordering. Okay, there are different classes. The two broadest classes are known as bacteriostatic and bactericidal. Static antibiotics just prevent bacteria from growing. Cidal antibiotics actually kill the bacteria. And here are some classes. Bactericidal, these include things like penicillins, cephalosporins, vancomycin. Bacteriostatic are like your erythromycin, tetracyclines. I don't know why they didn't talk about the classes, but we will here in just a bit. Okay, broad versus narrow spectrum, that's another way we can classify them. So here I have some broad spectrum, some narrow spectrum. This is just a table right out of your book here, guys. I'm not going to require you to memorize all this stuff, okay? There are a few things that we need to memorize for respiratory, but this isn't one of them. It's good to know, though. Okay, mechanism of action, different categories. Basically, we can do several things when we talk about dealing with a bacteria. And it's kind of like dealing with a human being, I suppose, in a way. I can shoot you or stab you, right? That'll kill you, right? hopefully, maybe. I can shoot you or stab you. I can break the integrity of your skin and all that, right? And I can do the same thing with bacteria. I can inhibit their cell wall. I can break their cell wall down. And that things like penicillins and cephalosporins, your beta-lactam type antibiotics, work on cell wall. Okay? I can inhibit protein synthesis. Right? If cells can't produce proteins, are they going to be able to grow and prosper and divide and all that? No, they're not. I can alter the synthesis of nucleic acid. Nucleic acid. Well, we kind of need nucleic acid, don't we? Right? Our genetic material kind of depends on that. I can also work in ways that are mysterious. Mysterious. We don't know. There's a lot of that in medicine. And have you guys had a chance to look through some drug guides and look at some of the medications? When you do, you'll see a lot of mechanism of action is not well understood. You see a lot of that. A lot of this is not well understood. Okay, classifications, yep. Beta-lactams, aminoglycosides, protein inhibitors, fluoroquinolones, all kinds of different classes. Let's talk about the beta-lactams real quick. Does anyone know what a beta-lactam is? What the structure is? It's actually a ring. It's called a beta-lactam ring. And we can break that ring down, and that'll help degrade the wall of certain types of bacteria. Antibiotics that fall into this class are things like penicillins, cephalosporins, monobactams are the three big ones that we talk about here. Even things like vancomycin will work on the ring as well. Penicillins, well, we know penicillin really well, right? Because it's been around for so long. It's generally pretty safe medications. Sometimes we'll give it prophylactically. Say somebody had a heart valve replaced, and they're going to have some maybe dental work done. We will give them penicillin prophylactically. We're actually finding that maybe this is probably not the best thing to do anymore, so that's kind of going away. They're generally not very toxic, generally well tolerated, but what we're running into commonly are allergies to penicillin. 15 to 20% of the population right now is allergic to. That's a pretty significant number of people that are allergic to penicillin. I have different types. I have my natural, my aminopenicillin, my penicillinase resistant, my extended spectrum, beta-lactamase inhibitors, and so on and so forth. These all are penicillins. They all work on the cell wall. Okay, you're not going to have to memorize all these little details here. Okay, cephalosporins. Cephalosporins are very similar to penicillins. They work on the cell wall. Okay, very similar mechanism action, but they have a longer half-life, and you don't have to give them as frequently. Generally, these are given IV, a lot of the ones we see. There are currently about 4 generations of cephalosporins. Generation 1, 2, 3, 4. What do you think those generations represent?
Stronger than medicine.
What's that?
Stronger than medicine.
Stronger? The time they were developed?
No.
What the generation of cephalosporins refers to is what type of bacteria they work against. Gram-positive or negative. That's actually where the generations come in. You have first, second, third, and fourth. The most common ones that we run into are the third generation, the rocephin or ceftriaxone. Very common. You will see this given very commonly. And you often will see Keflex and Kefzol or Ancef given as well, your first generation. And basically, what this relates to is your first generation cephalosporins are a little better at gram-negatives, and then as I move up, I get better at gram-positives, and then your third and fourth generation are actually what we call broad spectrum. They work very well against both positive and negative. Monobactams, these are newer synthetic. These are the answer to drug-resistant organisms, and guess what? We don't have very many of them. As of about 2007, when this came out, Azactam was the only available drug in this newer synthetic class. We actually have other ones now. have broad spectrum activity against gram-negatives, some gram-positives, but guess what? We already have bacteria resistant to these. Yeah, scary. Penims, Permixin, and Marum. Permaxin is probably the most common one that you'll see used here in Las Cruces. Permaxin is given IV. It's a broad spectrum. Generally, you'll see it given for resistant organisms like MRSA or VRE. Fluoroquinolones. Fluoroquinolones actually block enzymes responsible for DNA growth, so this stuff here. Negram is one they talk about. Lots of drug interactions. It's phototoxic. So patients, a lot of these antibiotics are actually like tetracycline, for example. They often tell people, you probably want to be real careful about being in the sun. Again, this isn't a medication that we're really going to be dealing with a whole lot in respiratory. Quinolones are good because they have good penetration. I can penetrate deeper tissues like bone and joint infections. And we know that bone and joint infections, is there a lot of circulation going in there? Is there a lot of perfusion? They get a lot of nutrients? Certain bones, but joints, certainly not, right? The synovium is a very avascular material. And if I injure my joint, for example, do they heal very well? No, right? So I've blown out a few vertebrae, a few discs in my lumbar spine, and that's not going to heal, right? It's not going to get better. Common fluoroquinolones include Cipro or ciprofloxacin or Levaquin. These are the two common ones that you run into, Cipro and Levaquin. You see a lot of Levaquin or levofloxacin given for certain pneumonias. We all know Cipro, right? What do they tell you about Cipro? If you go to Mexico, they say something about taking it to prevent traveler's diarrhea, right? E. coli, one of the big things we use Cipro for. Unfortunately, now a lot of traveler's diarrhea, Cipro is resistant, or the E. coli is resistant to Cipro. So oftentimes, what I do when I travel overseas is I take Levaquin instead of Cipro. I have better coverage with Levaquin if I happen to get diarrhea. If you're going to spend a lot of time overseas, what I'd recommend is just go over there, get sick, have your diarrhea, and you'll get over it. And that's actually how they dealt with us in Afghanistan. We came in and they're like, okay, we're going to give you 2 weeks to basically be lazy and do nothing. I'm like, hey, I came here to work. Like, well, you're not going to be working. I feel fine. Sure enough, 2-3 days later, throwing up, diarrhea, and after about a week I got better, got acclimatized, and I was able to eat the local food and do okay. So pretty amazing that American could actually do that. We're not used to that, but yeah. Okay, aminoglycosides is another type. Garmycin, tobramycin, you'll see those. Gentamicin, I'll talk a little bit about that here in just a little bit because it is a medication that we can give respiratory-wise. What does Odo Toxic mean? To the what? No. Odo means ear. Toxic, to hear it. Nephrotoxic, that hits the kidneys. So these aminoglycosides are actually really toxic. We need to be very careful about giving them. Often you'll see these given to kids that have meningitis. Vancomycin. We know vancomycin because this is a common medication we use to treat MRSA, right? Or methicillin resistant. If it's VRE, or we call vancomycin resistant, then vancomycin isn't going to work. It is very potent against Staph aureus, and Staph epidermis. Frequently reserved for MRSA infections, but more and more we're finding VRE type infections. Okay, this is a glycopeptide, targalicid. It's an alternative to vanc. Potentially useful to increase vanc resistance. Not something you guys are going to deal with a whole lot in respiratory. Protein synthesis inhibitors. Macrolides are very common. One of the most common macrolides, a protein synthesis inhibitor, is azithramax or azithromycin. And these are the ones that inhibit the ribosomal subunits that I talked about earlier. These are generally, at least like azithromycin, is going to be bacterial static. So they don't actually kill bacteria, they just prevent bacteria from growing and hopefully the body's natural immune response, normal immune response, will take those bacteria out. Tetracyclines, we see these. These are broad spectrum. Should not be taken with a variety of things. Pregnant women and children should not take due to permanent tooth discoloration. This actually happened to my wife when her mother was pregnant. Her mom was put on tetracycline type medication, and now Cheryl has stained teeth because of that. Can cause serious, okay, yeah, that's with any medication if it's expired. Doxycycline, minocycline, and tetracycline are all examples you'll run into. Folate inhibitors. So these inhibit folic acid. They inhibit bacterial folic acid, and the bacteria can't create things like vitamin D because of this. And can't create energy. The big ones that we run into are Septra and Bactrim here. And has anyone here ever had a urinary tract infection or UTI? If you've had, they may have put you on Bactrim, unless you're allergic to sulfa. If you're allergic to sulfa, not a good idea to use the folate inhibitors, because these are sulfa-based antibiotics. Okay, oxazolidinones, whatever that is, Zyvox, you might see that in bacteriostatic. Again, not something we're going to run into. You will see this, the Zyvox particularly used in community-acquired pneumonias and nosocomial infections. So patients that get VAP or ventilator-associated pneumonia. Okay, that's nothing we... Okay, metronidazole or Flagyl. You'll see this used for lots of anaerobic infections. And metronidazole works against protozoal infections. Amoebic dysentery, for example, so some real interesting. Intolerance to alcohol and metallic taste. Yeah, if somebody's on Flagyl, you don't want them to be drinking because they'll have what's called a disulfiram-like reaction. You guys know what disulfiram is? It's called antabuse. Sometimes they give that to alcoholics, and if they drink alcohol, they throw up and they just, feel really horrible. Well, they have a very similar reaction with Flagyl. They throw up and just get really sick. Okay, tuberculosis. Is this a big issue with us in respiratory? Yeah, it is. Do we have strains of tuberculosis that are resistant to every known antibiotic? Yes, unfortunately we do. It's called MDR-TB, or multi-drug resistant tuberculosis. We're seeing this in Mexico now. We're also seeing this in countries like Russia, or what do they call them? Russia now, yeah, in prison populations. So we have lots of different TB drugs out there. First line are your primary, and then second are like your retreatment medications. They need follow-up therapy. So some of your primary medications, isoniazid or INH, it's very common. We're not giving it quite as much anymore because of all the resistance. You'll see rifampin used as well. And then, so these are the two common ones that you'll run into, especially on board tests. You'll run into these, isoniazid, rifampin. Secondary for retreatment, these are things like streptomycin and cycloserine. But certainly these top two here are noteworthy. Okay, viruses. Now getting into viruses. These are the most common infectious agents in humans. So if I have an infection and I want to take a bet, the bet is it'll probably be viral. They're very common. They're obligate parasites, which means that they need a host cell like we talked about earlier. And we talked about generally how they work. And do they work right away necessarily? No, they can have what's called latency period, where I have a virus kind of floating around in me, or maybe it's attached to a cell and it's just waiting. Waiting for maybe some immunocompromise to occur, or some stress or something like that, and then the infection takes off. How do we fight viruses? Do we have good antiviral medications? Not like antibiotics. Well, of course, antibiotics are kind of not working like they used to either. Our biggest line of defense against viruses have been immunizations. We have almost eradicated diseases that were devastating Polio, for example. Polio put respiratory therapy on the map in the United States. The polio epidemic. There are a lot of people that were on iron lungs. You guys know what iron lungs are, hopefully. You've learned about those in lab a little bit. Negative pressure ventilation. Okay. If not, I just look it up. Look up iron lung. The form of negative pressure ventilation. And then subsequently ventilators. So polio kind of put, and I know Mrs. Durant was going to look at maybe doing a little history with you guys. Have you guys done a little history? I know that's something she's thinking about, history of respiratory therapy. This was a big turning point for us in respiratory therapy, put us on the map in the U.S. Do we have respiratory therapists in other countries like we do in the United States? What do you guys think? We don't. We have them in Canada, we have them in the U.S., and we have something like an RT in Mexico. Guess what? We don't have them anywhere else in the world. We have physical therapists, or what are called physiotherapists in other countries, that do extra training to learn how to do respiratory therapy. Very different in the United States. But the whole respiratory, it kind of really took off during the polio epidemic. Because prior to this, we would just come into the hospital and put a tank of oxygen in there and go, all right, thanks, have a good day, and take off. That's what we did. That's all the training we had, a few hours in safety. And they called them inhalation technicians at one point when we started doing treatments. But after this, boom, we started having formal programs developed for respiratory therapy. Okay, and rubella. But we've gotten measles, mumps, and rubella. We have very good effective vaccines against those. Polio, of course. But how many of us are vaccinated against polio right now? Probably, if you're probably 40 and above, you may have been. If you're less than 40 or even 45, you probably haven't. Like, any of you guys in the back, have you had a polio vaccine? No, not anymore. Yeah, we don't really do it anymore in the U.S. because they say it's eradicated, but we're actually seeing some polio coming back in the African area. We're seeing some cases of it, so it's not totally eradicated. HIV, that a big deal? Yeah, that is a really big deal. We don't have an effective vaccine against that, but do we have effective treatments? Do we have effective antiviral treatments? Yeah. 20 years ago, if I were to tell you, well, you have HIV, what would you do? You'd be like, well, I'm going to be dead in 20 years. Okay, that was a death sentence. If I tell you have HIV today, right here, right now, is that a death sentence? Nope. Could be managed, right? We can manage lots of cases of HIV very effectively and manage it, like diabetes. People can go on to live fairly long, healthy lives in some cases. That's just how good our medications have gotten, our antivirals for HIV. It's pretty amazing, actually. Pretty amazing. Herpes is a DNA virus. Can cause genital herpes, also things like cold sores and shingles as well. People that have had chickenpox. Chickenpox is the varicella. We do have good treatments. Zovirax, acyclovir, Valtrix. We have different types of medications we can use. Antivirals for influenza or the flu. We we have decent antiviral medications for the flu. Sort of. Yeah, sort of. When the swine flu came through, obviously we're giving people lots of Tamiflu, and that was sort of effective. You guys know Mr. Duran actually got swine flu. When I was in school, in respiratory school, he actually got it and got pretty sick too. I think his son got it too. They were really sick. So he got through it. RSV. Okay, this is a blue light special here, guys, because this is something we run into. Well, we don't really run into it a whole lot, but they love to ask this stuff on tests. RSV is respiratory syncytial virus. Very common. When you guys start clinicals next semester, you will be in RSV season. What kinds of patients get RSV? Kiddos, yeah, kiddos, little kiddos. There is a medication that we can give, It's called ribavirin. Okay, it inhibits the activity of RSV, and in some cases can be used to treat certain types of influenza. The thing we need to know about giving ribavirin or Virazole is we need to administer it through a special nebulizer called a SPAG, and that is a small particle aerosol generator, is a SPAG unit. And they love to ask this on test after test after test, even though I've never given a ribavirin. I hear it's still given around here occasionally, but I've never given it. So it's not as common as it once was. But they still love to ask these questions, in general, particularly about how we give it. And we would give that through a SPAG, or a small particle aerosol generator. Okay, different types of antiviral agents there. To treat, okay. I'd cross this out and put HIV, right? Treat HIV. HIV is a progressively fatal disease that can lead to AIDS, right? Because AIDS is the end, kind of the end game of HIV. Okay? Treatment of it, several different drugs. Several vaccines are undergoing testing. Nothing has really panned out yet. Well, you know, there's some promise, but nothing yet. I'm not going to make you guys memorize all of these what we call antiretrovirals, right? Because HIV is a retrovirus. It contains the enzyme reverse transcriptase and so on and so forth. But I'm not going to make you memorize all of these medications. Just know that we do have antiretroviral agents out there for treating HIV. We have different classes of them. Some of them work on reverse transcriptase, others work on protease, the protease enzyme. Okay, almost at the end, guys. We're getting there, okay? This is a class of what we call antifungal agents. What kind of cell is a fungus? What's that? A prokaryotic or eukaryotic? Okay, eukaryotic cells. Okay, so we need to use the antibiotics are not going to work for the most part against these guys. Antifungals, fungus can produce spores. They can have a rigid wall. Obviously, I don't know why I even threw the chlorophyll thing in here, because chlorophyll is more of a plant, right? Plants use chlorophyll in production of ATP. Examples can include mushrooms, yeast, different types of molds. Okay. Fungal infection is most likely to develop in an impaired immune system. I would put that as a blue light special for us.
Which was?
A fungal infection is most likely to develop with an impaired immune system. Some of the medications that we run into are like nystatin or mycostatin. It's an oral topical to treat Candida albicans. Okay. This is a blue light special here that you'll run into. An aerosolized medication that we can give to treat people that have fungal infections of the airway is amphotericin B. You can aerosolize it and has been used to treat fungal lung infections. What kinds of patients do we probably see these types of fungal infections in? Immunocompromised. What specific disorders? What do you guys think? So what are the major disorders that cause immunocompromise in patients? HIV. HIV, that's a big one. Good. What else? Cancer? Cancer patients that are receiving chemotherapy for their cancer? Yeah, absolutely. Absolutely. Those are the two big groups. And elderly debilitated patients that have multiple chronic issues. Okay, so just a laundry list of medications there. Again, I'm not going to require you to memorize all these, but I would like you to know about amphotericin B, because not only is it given IV systemically, but we can aerosolize it too. Okay, aerosol anti-infective therapy. Okay, finally we're getting to stuff that's more relevant to us. Most pulmonary infections are treated systemically, right? Generally either give you an oral medication, or if the first pass effect is an issue, I'll give you IV medication. Disadvantage of, the advantages of aerosolizing it is, can I get good penetration right to infected lung tissue? Yeah, in a lot of cases I can. So I don't have systemic antibiotics. I don't have antibiotics throughout my entire body. Disadvantages, it can cause bronchospasm. A lot of times I need special equipment, I need to have filters and things like that. And if I have deposition on mucus, mucus, as we know, contains lots of different enzymes, and it can deactivate some of the antibiotics that we give. Okay, penetrating with a bronchodilator may be advantageous. Often we will give bronchodilators with our inhaled antibiotics. I would recommend that if a physician orders that, you would at least want to ask them if they want to consider a bronchodilator, just because you can get lots of The patients that we often see inhaled antibiotics on are TB and or cystic fibrosis. Cystic fibrosis here. Cystic fibrosis patients, it's obstructive, right? They have lots of mucus buildup. They have a hard time getting that mucus out, and that mucus is a breeding ground for bacteria. So often you will see patients that have cystic fibrosis on nebulized antibiotics as preventative, or what we call prophylactic therapy. This is not uncommon to see that. And that is the end there. If you guys, let's go ahead and take 5-10 minutes. Take a 10-minute break, and I will wrap it up. Just a couple more things I want to emphasize, and we'll be done.